Hey everybody, this is Rusty and we're going to continue our patient assessment presentation. This is part 2 of 2 and we're going to talk about a more detailed assessment. All right, let's continue this detailed exam. We assessed, we treated, we reassessed, so it's time to listen to lung sounds again. On scene might have been a little noisier than in the back of your ambulance, so let's get another listen to those lungs. Our patient's always right, so we're going to start at number 1. And if you notice, we're a little closer to the sternum, so we can listen to the bronchi, because you just might hear the rhonchi in the bronchi. So let's go right, left, 1, 2, move on down a little bit, left, right, 3, 4, move on down a little bit, go right, left, 5, 6, to listen to those lung sounds. Like I said, if they have a difficulty breathing chief complaint, you may lean them forward, have them hug themselves by putting their hands on their elbows, which stretches those scapula out so you can get that stethoscope a little easier between their spinal column and the scapulas. Start at the top and compare one side to the other, right, left, go down to the middle area, left, right, go down to the lower area, right, left. So you can hear those crackles and the backles. And that's a detailed of those lung sounds. Once you're done with those lung sounds, right, left, left, right, right, left. It's time for heart, heart, heart. So we're going to start off with number 7, the point of maximum impulse, 5th intercostal space, mid-clavicular line. And then we're going to go up to S1, which is left sternal border, 4th intercostal space, and then we're going to go to S2, which is the dub, and number 9, 2nd intercostal space, right sternal border. And then if they have some congestive heart failure, you may hear the S3 in that right, or I should say the 2nd intercostal space, left sternal border, that lub dub D or Kentucky. Lub dub D, Kentucky, can be indicative of congestive heart failure. And that's a detailed heart exam. When your patient has an abdominal complaint, you need to do a good assessment of that area. The 4 steps to that assessment is IAPP. Inspect, auscultate, palpate, and percuss. When you inspect, you're going to look for scars, masses, pulsations, any distension. Or you're going to look for bruising. Bruising around your belly button is called Cullen's sign. Cullen, the C in Cullen, is shaped like a circle, and your belly button, well, it's sort of round too. So associate those two to remember Cullen's sign. Then bruising in your flanks or on the sides is Gray Turner's sign. You turn with your sides, so if you have bruising in your sides, you have Gray Turner's sign. Then you're going to auscultate. Sometimes it's hard to appreciate that in a noisy ambulance, but you're just going to listen in all 4 quadrants. 20 to 30 seconds for normal clicks and gurgles of digestion. And then you move on to palpation. You're going to ask your patient with one finger, number 1, because they're your number 1 patient right now, to point at the pain. They're going to point at it, and you're going to start in the quadrant furthest away from that pain and move towards it. You're going to start with a light palpation, just pushing down lightly in each quadrant, and then a deeper palpation in each quadrant, and then you're going to push down and let up real quick to get that rebound tenderness with the palpation. So percussion is part of the assessment, but it's difficult to appreciate in a noisy ambulance, so it's rarely done. You need to know what organs, abdominal organs, are in each quadrant. So that will help you get a differential diagnosis of various disease processes. One location is McBurney's Point. It is 1/3 the distance from the right iliac crest to the belly button is McBurney's Point, and it just happens to be where your appendix is. Another sign that you need to be aware of is Rovsing's sign. You could be doing that palpation on that left lower quadrant, and it gives the patient a pain on the right side. That is also indicative of appendicitis. So be careful or be cognizant of those various signs. All right, if the chief complaint is somewhere in the head, we're going to inspect that. H-E-E-N-T, head, ears, eyes, nose, and throat. We're going to start with the head, inspecting for symmetry, palpating for lumps, bumps, and depressions, and then moving on to the ears. Inspecting inside the ear for any type of drainage and behind the ear for bruising. Then we're moving to the eyes, inspecting for the color of the sclera. Scleral icterus means your eyes are yellow, and that can be indicative of liver failure. So notice the color of the sclera. And then you're going to test cranial nerves 3, 4, and 6 by having the patient follow your finger with just their eyes and make a big letter H with just their eyes to ensure their pupils are equal, round, react to light, and they do accommodate. Then we're inspecting the nose for straightness and then determining which nair is bigger, just in case we have to do a nasal intubation. And then we're having them open their mouth and say, ah, looking for broken teeth, a uvula position, and any blood in the mouth. And that's your inspection of H-E-E-N-T. With the neck, cervical spine, and long spine, we're going to inspect for symmetry. Do they have kyptosis, leaning forward a little bit, lordosis, leaning backwards some, or scoliosis in that lateral curvature of the spine? And then you're going to palpate and let your fingers do the walking from C2 through C7 of the C-spine, and then from your thoracic to your lumbar spine. Let your fingers do the walking for step-offs and deviations. Ask the patients if they can wiggle their fingers and toes or if they have any numbness or tingling, pins and needles in those fingers and toes. If they do, you may need to take some spinal precautions. When doing an assessment on male and female genitalia and anus area, you need to keep the assessment discreet, and you always need to have a partner with you, normally of the same sex as the patient. So typically this isn't done for normal medical calls unless it is OB pregnancy and you're delivering a baby. But there could be trauma to the area, so it needs to be inspected. Especially on trauma patients, you roll them on the backboard, palpate the back of the head, that long spine like we just talked to, and then you need to look for bright red bleeding coming from the rectum. Because if it's bright red, it's arterial, and if it's coming from the rectum, well, we can't put a tourniquet on it or pack the wound. They need surgery now. So keep it discreet. Have a same-sex partner with you to inspect and assess the male and female genitalia. Inspecting or assessing the musculoskeletal system and the range of motion. Normal range of motions for each area, as long as there's no trauma associated with it. Starting with that head, moving to the feet. You're going to move the head in all ranges of motion. Put your chin on the chest. Stick your nose towards the ceiling of the sky. Rotate head to the left, to the right. Then chin, or I should say, ear to your one shoulder, ear to your other shoulder. And that's normal range of motion of the neck. Then you're moving your shoulders. Going to bring your arms out to the side, which is abduction, abduction, moving away from the center line of the body. And then you're going to drop those shoulders down, adduction. You're adding to the center line of the body. So that's lateral raises of the shoulders. Then you're going to pick your arms up in front of you, drop them back down, move them straight behind you, drop them back down, shrug your shoulders, cranial nerve 11, and that's shoulder positions. Then you're going to do a bicep curl up, bicep or tricep extension down, going to flex your wrist up, flex your wrist down. You're going to squeeze and make a fist, and then you're going to spread your fingers. That's wrists and hands. You're going to lift your leg up at the hips, then extend it back at the hips, and then out to the side and across the body for your hip motions, front, back, side to sides with each side. Flex the knee out by straightening your leg, curl it back, hamstring, and around in circles for that knee joint. Same thing with the ankles, up, down, around and round, or normal range of motions for the ankles. Then you're going to curl those toes and extend them out for those toe joint range of motions. And that's head to toe range of motion and the musculoskeletal system. Next, we're going to assess the nervous system, myotones and dermatones. The dermatones are your sensory nerves. Your myotones make your muscles move. So dermatones are better understood with a person bent over because all of the levels of dermatones are falling from top to bottom. So we're going the same direction. When we assess these dermatones in the extremities, we're going from the back to the front of the arm, above the elbow, and then below the elbow. And then from the back to the front of the legs, above the knee and below the knee, to assess those dermatones. When you're doing dermatones on the torso, you're going from the hips to the shoulders, each side separately. Do the right side and then do the left side, right in that nipple line area, or midclavicular nipple line, from the pelvis to there. We're testing light touch, like just your fingers, or a deeper touch, or a pain, pressing a little harder, or use the edge of your bandage scissors. We'll talk about what those mean in neurology class. But that's a light touch and a deep touch or pain for your dermatones. With your myotones, well, you're just going to go through some range of motions. So C5 and 6 is that bicep curl. C7 is that tricep extension. C8 is gripping or squeezing your fingers. And T1 is spreading those fingers out really wide. So then we go all the way down to S1, plantar flexion, like pushing gas on the pedal, plantar flexion, and then bringing those toes towards your head is L4. So that's the normal myotones we test on trauma patients. When we're talking about lab values in the field, well, we can start an IV and draw labs in the standard tubing to give to the ER nurses. So other lab values we can get are, well, hey, our full set of vital signs. I'm sure you've forgotten the jingle, so we need to review it again. TPR, BP, O2, glue, and tidal, CO2, ECG, and LOC, skin, and I say yes, sirree. That's our full set of vital signs. TPR, BP, O2, glue, and tidal, CO2, ECG, and LOC, skin, and I say yes, sirree. So when you're thinking about lab values, getting those tubes of blood for the nurses in the ER, then do another full set of vital signs. Some other considerations in your patient assessment are special populations like our older adults. Respect your elders. Your parents should have taught you that a long time ago when you were a little kid. So respect, respect, respect. Take into consideration that they have comorbidities and they can be on multiple medications. So in that patient history, make sure they're taking all of those meds at the correct time so they're working properly. And then consider any disabilities with aging. Disabilities with mobility, wheelchairs, walkers, things like that. Dementia, Alzheimer's, or they just might have a slower thought process to answer all your questions. Remember, when you're getting a history It's about communication, not interrogation. So if they have trouble hearing, well, don't scream at them. Talk in a normal tone. You might have to write things down. And if they have some type of disability and some kind of assisting device, make sure you take it with you. Take their glasses, take their dentures, take their hearing aids, things like that when you go to the hospital. Other special considerations is the need for aeromedical, or the need for speed. So advantages: they can get to the hospital quicker, they can do more procedures, and they carry blood products. So you might need that in your patients. So that's some advantages. Some disadvantages: well, unless you put them on standby, they're going to have to get to the helicopter, get it cranked up, and then get to you. So if it sounds bad by dispatch, it's better to put them on standby and cancel them than to not put them on and need them and they get there slowly. So you got to assess that need for speed, and if it's quicker for you to load them up and start moving, then the helicopter will start cranking up and come to you. So, but if you need them, they are there. And to end things off, it is the circle of assessment. We assess, we treat, we reassess. We do a procedure. On that reassessment, we check those IVs, make sure it's not infiltrating, make sure it's not infected, things like that. We make sure it's dripping, the IV fluid's dripping at the rate we need to. We reassess those vital signs. We reassess that skin, color, temperature, texture. We reassess those eyes, especially on brain trauma patients. We assess, we treat, we reassess, and treat again as needed to determine if our patient's getting better or getting worse. We assess, we treat, we reassess on all of our patients. Hopefully you enjoyed the presentation, and I hope you have a great day.